All right. So I was asked to give a talk on cardiac manifestations of myotonic dystrophy type 2. And I will say that it is a little bit challenging in the sense that there isn't a lot of objective data to provide you. I do have some slides that are type 2 specific, and as much as possible, I will distinguish between type 2 and type 1 data. And so those of you who may know me, I've recently joined Kansas. For last 25 years. I was on faculty at UT Southwestern in Dallas. These are my disclosures. And those of you who know me, I'm a big sports fan. And for the last 25 years, I got to root for many Texas teams, although I will say I'm not a Cowboys fan. And so moving up to Kansas, I got to root for the Chiefs, but I'm actually born and raised in Wisconsin, and so I'm a cheesehead through and through. So that's my big disclaimer. So I'm also a physician scientist. I'm a clinician, and one of the, as we enter the 2023, advances in medicine is now really a collaboration between academia, industry, and government, the NIH. As we make discoveries at the bench, we take it to clinical trials, and if they're successful, they go into clinical therapies. And then it raises more questions for us to go back to the bench to understand questions. And so it's this vicious cycle. But prior to 20 years ago, we were primarily, most of the work was done at the bench, but now it's a collaboration between three teams, which is incredibly exciting, and it will advance the science, particularly in rare diseases. So this is my outline, my talk. I'm going to kind of distinguish between type 1 and type 2, talk about some of the cardiovascular effects in type 1 and type 2, and then the assessment that I've developed over the last 10, 15 years in terms of cardiovascular assessment. And then I'll give some take-home messages. And feel free to ask me questions. This is, and I'll leave about 15 minutes at the end for also questions and answers. So myotonic dystrophy. So as many of you know, type 1 and type 2. Type 1 is the most prominent form of myotonic dystrophy, but type 2 is also about 5 to 10% of myotonics are type 2. They're both autosomal dominant. Type 1 is due to these repeats, these CTG repeats in the 3' end of a gene called DMPK. While in type 2, there is these repeats CCTG in the 3' region of this gene called CNBP that results in splicing defects. And these are both systemic diseases. Between type 1 and type 2, there are differences in the repeats. In type 1, they're usually moderate to severe, between 50 to 4,000. But in type 2, they can range up to 10,000 repeats. In type 2, we see that it's predominantly male, female are about equal. But one difference between type 1 and type 2 is that maternal transmission is greater in type 1 versus type 2. And a lot of this data is relatively not very recent, but within the last 10 years. So as I mentioned, both type 1 and type 2, the symptoms are systemic. But for this talk, we're going to primarily talk about cardiovascular. It is believed that rhythm issues that can affect both type 1 and type 2 are less prominent in type 2, but it's not zero. It is significant still. Restrictive lung disease is also prominent in type 2. And the effects on anesthesia is not very clear, but in general, we follow the guidelines for type 1 that we avoid certain anesthetics, in particular what's called succinylcholine sedatives, puts patients with myotonic dystrophy patients at risk for what's called malignant hyperthermia. So it's very important if you're undergoing any type of surgeries that you let the anesthesiologist know that you have myotonic dystrophy. And then in terms of pregnancy, it's unknown, the risk in type 2s. if you undergo pregnancy. In general, it's felt that the symptoms get worse during pregnancy, but improve after delivery. If you compare type 1 and type 2, there are some differences. In type 1, it does affect all races, while in type 2, in general, it affects predominantly people of European descent, in particular, people of Northern European descent. While type 1 affects from all ages, type 2 is more later onset in adulthood. And life expectancy is believed to be relatively normal in type 2, while it's reduced in type 1. As I mentioned, restrictive lung disease is more prevalent in type 1, but it's not unusual for type 2s to also have some weakness of the diaphragm. In cardiac arrhythmias, it's very prominent in type 1, but it's variable in type 2. So I'm going to talk a little more data between type 1 and 2 from a cardiovascular standpoint. And if I'm a little vague in terms of numbers, it's because we just don't know. And I'm giving my best opinion based on the data we have and based on my experience over the last 15 years. So this was a study, almost 10 years old, looking at ambulation between type 1, which is in blue, and type 2, which is in red, over time. And you can see that in type 2s, ambulation is less of a problem as compared to type 1. As I mentioned, that since this type 2 affects predominantly older Americans versus, not Americans, but older individuals versus type 1, many of the risk factors that we see that occur with older age is more prevalent in type 2, right? So hypertension, diabetes is more prevalent in type 2 than type 1. Is that because it's more prevalent in the disease or because individuals are older? It's very difficult to tease out from the limited data we have. And in the study, they looked at various parameters from a cardiovascular standpoint. One thing is clear is that arrhythmias tend to be less. And if you look at the PR interval, which we'll talk about a little later, which is the rate or the time it takes from a signal to go from the SA node to the AV node, and I'll explain that a little later, it's less prominent in DM2 versus DM1, as you can see here. And the QRS interval is a little shorter compared to DM1. And I'll explain what that means here later on. Now, and also predominantly how cardiologists evaluate cardiac function in not only myotonic, but all muscular dystrophies is by echo. And you can see here, the ejection fraction is relatively similar and relatively normal between the two, but echo is really an insensitive way to look at the heart. And as I'll describe, cardiac MRI is really the gold standard in not only myotonic, but also in all forms of muscular dystrophy to look at how weak the heart is. So following up on the study, they did a follow-up study. I think it was a 10-year follow-up study. And you can see here the rate of increase in the PR interval is greater in DM2 than DM1, but still it's less than DM1. And the QRS interval also rises at a faster rate compared to DM1. Unlike in DM1, the ejection fraction seems to decrease a little faster in DM2 compared to DM1. Once again, this is by echocardiogram. If you look here, and this is looking at a variety of long-term outcomes from death to use of non-invasive ventilator support, pacemaker implantations, and ICDs. Blue is type 1 and red is type 2. Although it appears that you see less effects over time, and the x-axis is time, in DM2 versus DM1, the p-value is really insignificant. The numbers are small, and so even though there appears to be a difference, there's no difference between the two disease states. I know this may be a little bit hard to read, but there's a point that I'm bringing here. So this is a study, a German group that looked at the metabolic syndrome that occurs in type 2 diabetes using cardiac MRI. And two things I do want to highlight. So this is a small study, 27 DM2s, and they compared the results to healthy controls. So there was no DM1s. And in the DM2s, they looked at metabolic syndromes between those that had what's called delayed enhancement or scarring in the heart versus those that had no scarring or LGE negative, okay? And what you can see is that if you had an MRI that you didn't show any signs of delayed enhancement, you were tended to be younger. But if you looked at the actual MRI results, if you had delayed enhancement, your ejection fraction was lower, your hearts were a little bit bigger, and they were heavier compared if you did not have any scarring. And other risk factors were actually more prevalent in those that had delayed enhancement, clouding some of this data. So more of the type 2s that had delayed enhancement or LGE were more likely to have hyperlipidemia, diabetes, smokers. So this data is not, this is all retrospective data. So it's not clear data, but it's the only data we have in the literature right now. So one of the issues that we as cardiologists have is trying to predict who may need a pacemaker, who should we start on therapy for a cardiomyopathy. And although we don't have any data for type 2, there is a pretty well-designed study by the French group looking at type 1s. So Karim Wasby, who is a cardiologist in Paris, and they have perhaps one of the largest populations of type 1 myotonic, so over 1,000 patients they've been following. He tried to develop a score to predict how likely you would survive after 10 years. And so he looked at various variables. Your age, so the older you were, the more points you got. If you had diabetes, you got points. If you were less ambulatory, you got points. If you had more bradycardia, lower heart rate, you got points. If you had more hypotension or lower blood pressure, you got points. And also they looked at respiratory status. And so the more points you had, then your 10-year survival was lower compared to if you had lower points. And another way to put this is looking at those that had lower scores, so 0 to 4, your outcomes after 10 years was actually pretty good, almost 95%. Well, if you had 14 to 20 points, your risk of surviving past 10 years was pretty low. And once again, this is for type 1s. We don't have any data related to type 2s using this predictive model. But this was a prospective study, a very well done study, one of the few kind of really well done controlled studies that the French group did. And so I'm going to, the big thing is cardiomyopathies and arrhythmias in type 1 and type 2. And I'm going to kind of go over how we assess using the data we have in patients with type 1 and type 2. But as I've already alluded to, part of the problem in not only myotonic, but all dystrophies is, we have not included any muscular dystrophy patients in our large clinical heart failure and arrhythmia trials. Cardiovascular disease is very much evidence-based. We have these mega trials, 5,000, 10,000 patients. We don't have that luxury in muscular dystrophy, and patients are excluded from these large trials. There's very limited randomized controlled trials in muscular dystrophy. The only trials that I'm aware looking at cardiovascular outcomes in muscular dystrophy is actually in Duchenne's muscular dystrophy. And we have to extrapolate from Duchenne's and other forms of cardiovascular disease to myotonic dystrophy in terms of therapies. And along the same lines, there's very limited guidelines from our organizations. There is a recent guideline that the American Heart and the American College of Cardiology that put together about 5 years ago. And then our group, Dr. McNally at Northwestern and me and a few other experts did do a general guidelines of therapies for myotonic dystrophy in general. And that got published about 3 years ago. But it is a very general approach to patients with cardiovascular disease in myotonic dystrophy 1 and 2. So as I mentioned, for the last 15 years, I developed this clinic at UT, and I actually am developing a new clinic at University of Kansas. Jeff Statlin runs a very large neuromuscular clinic at Kansas, and I've actually collaborated with my colleagues at UT, and hopefully some of the data that we've collected over the last 13 years, we will be putting out in press so that we have more objective data of how we treat patients with myotonic dystrophy. So our clinic at UT was established in 2010. It is really one of the few clinics in the country that's driven by heart failure cardiologists. And today we've taken care of about 1,000 patients. And we see about 10 new patients a month. Unfortunately, since my departure, they've had a little difficulty finding another heart failure cardiologist to see many of these patients. That's unfortunate. How we developed this clinic and established it was we reached out to the pediatricians and the adult neuromuscular neurologists to feed in referrals to our clinic. And we also started developing referrals to all of North Texas and surrounding states. And towards the end of my tenure at Southwestern, we were getting referrals from both coasts, as well as from Texas, Louisiana, New Mexico, and Oklahoma. And we developed a protocol to objectively assess patients with muscular dystrophy. And the key is being objective and focusing on objective measures, which I'll go over here. So as a patient comes into our clinic, and this applies to all muscular dystrophy patients, not just type 1 or type 2 myotonic dystrophy. We phenotype them molecularly as well as clinically. We assess their electrical properties by an EKG and Holter, and we image predominantly by MRI. I would say 70% of our patients we image by MRI, and I'll try and highlight why we do that. So this is a meta-analysis of a variety of studies looking at myotonic type 1 and 2. And if you look here, the male-female ratio was about equal 50-50. The risk of developing arrhythmia, regardless if you're type 1 and type 2, was about 25 to 30% if you add up all the arrhythmias, atrial fibrillation, SVT, ventricular arrhythmias. The risk of having LV dysfunction or cardiomyopathy or heart failure in this meta-analysis was about 7 to 10%. But remember, they assessed cardiac function by echocardiogram. This study is almost 11 years old, and almost very few of us assess now cardiac function by echo. This was a protocol that Beth McNally, I view Beth as kind of the godmother of neuromuscular cardiomyopathy. She's a cardiologist at Northwestern, proposed this protocol to assess myotonic dystrophy patients. So if your EKG showed elevated PR intervals, so slowing of conduction, and you had if that was the case, then we would oftentimes send you for an EP study. If you didn't have symptoms or the PR interval was not prolonged, then we would follow with every 6 months to 12 months an EKG or a Holter. If you had syncope or near syncope, then we would send you for an arrhythmia study. And we image, although here it says baseline echo or MRI, once again, MRI is really the go-to imaging tool. And we assess what therapies we would start patients on based on the MRI findings. And I will have a more detailed slide here in the next few slides. This is a protocol that I developed, how we objectively assess our patients. So biochemically, we get a bunch of blood work to allow us to calculate what's called the Seattle Heart Failure Score. It's a score that has been validated in other forms of cardiomyopathy, ischemic cardiomyopathy, hypertrophic cardiomyopathy, and we extrapolate that data to this setting. The Seattle Heart Failure Score predicts your risk of hospitalizations for when your heart gets weak. We look at your thyroid, the risk of diabetes, and what I call the cardiac and inflammatory markers. Because what we've shown, we've not yet published, that these cardiac and inflammatory markers kind of trend with individuals that are more likely to develop cardiovascular issues over time. It's an imperative that everyone gets genetic sequencing because the risk of cardiovascular disease appears to be correlated with the number of repeats one has. So the more repeats you have, the higher likelihood that of you developing cardiovascular disease over time. And this is for type 1 and type 2. Electrically, we get 12 lead EKG, we'll get a Holter, and in some we'll implant an implantable recorder if we're concerned about arrhythmias and we're not able to capture what the rhythm issue. Structurally, once again, MRI is really the gold standard. And we're looking, the reason we do MRI or cardiac CT is to get quantitative numbers. Echocardiogram is not a quantitative, it's a semi-quantitative way to look at cardiac function. And so if someone can't tolerate an MRI, then we'll go to a cardiac CT to get quantitative numbers of their ejection fraction, how well is the heart pumping, how big is the heart. And then we try and get a functional status. In myotonic dystrophy, many are ambulatory, and we try and get what's called a 6-minute walk, a very simple test, but it's reproducible over time to tell us your submaximal activity with walking 6 minutes. And those that can do cardiopulmonary stress tests, whether it's through a treadmill or a bike, it's another way for us to objectively assess one's ability to do functional capacity from a cardiorespiratory standpoint. As I mentioned, the prevalence of a cardiomyopathy in type 1s and type 2s is not clear. This study was actually in type 1s. It was also another meta-analysis. Most of this data was done about 2015 to 2017. There's some earlier studies. And they looked at the risk of developing LV dysfunction. And this is once again by ECHO. And this was published about 3-4 years ago. It's a meta-analysis again. And in this study, they predicted the risk of developing LV dysfunction, meaning heart failure or cardiomyopathy, is about 14%, 14 or 15%. Once someone develops a cardiomyopathy or weak heart, once again, we extrapolate our data of how we treat other forms of cardiomyopathy to patients with muscular dystrophy. And in general, treatment now is a 4-drug treatment. From beta blockers, and there are very specific beta blockers we use. These drugs called ACE inhibitors, ARBs, or ARNIs. In general, we favor ARNIs or Entresto. The problem with these drugs is they are potent on the blood pressure, and many myotonic dystrophy patients have problems with hypotension or low blood pressure. And so we're not able to oftentimes start or up-titrate these meds, right? MRAs are a class of drugs that they're very weak water pills, but the doses we give, their effects are pleiotropic. They make the beta blocker and these ACE inhibitors work more effectively. And there is some data that it breaks down scarring in the heart. In the newest class of drugs called SGLT2 inhibitors, which are very potent metabolic drugs, have been shown to be beneficial in cardiomyopathy patients, but has not been tested in muscular dystrophy, but we extrapolate the data. So I have here dystrophy misspelled. My apologies for that. And the 3 drugs I have in green, in general, we don't use in myotonic dystrophy because it does affect the conduction system. So those 3 we do not use in general in myotonic dystrophy patients. I will say that LVAD and heart transplantation, which is an extreme view or extreme therapy for muscular dystrophy. In myotonic dystrophy, based on my experience over the last 25 years at Southwestern, is rarely used. In my 25 years, we did transplant one patient with myotonic dystrophy, and he did very well. He lived about 15 extra years, and then unfortunately succumbed to an infection. We never ended up putting an LVAD into a patient. So transplantation is a rare therapy for for myotonic dystrophy. So I kept harping on MRI versus echo. And there are many reasons why we, not just me, but heart failure cardiologists favor cardiac MRI in neuromuscular patients, as well as patients with genetic cardiomyopathies, is the imaging quality is so much superior. And we have very good images of the right and left ventricles. We're able to identify myocardial fibrosis, or what we call delayed enhancement. You can't do that by echo. And the error rate by MRI is much lower than by echo. What many cardiologists don't tell their patients is by echo, if we say your ejection fraction is 40%, that's their error rate is 8 to 10%. So it could be 30%, it could be 50%. By MRI, the error rate's about 5%. And so it's a much more accurate and sensitive way to look at the cardiac function. And I put, well, based on large databases of what is normal here. The mean for RV is around 63%, while the left is 67 plus or minus 5, so 62, 60% is the lower range of normal. And so we developed an algorithm when I was at Southwestern of how we use the MRI and what kind of therapies we start if one develops LV dysfunction. If one has normal LV function and no signs of delayed enhancement, we'll start an ACE inhibitor like lisinopril and allopril or Entresto. That's what ARNI, ARNI stands for abbreviation. If you have normal ejection fraction but signs of delayed enhancement, your myocardium is not normal. And we'll start an ACE, like lisinopril, and an MRA, spironolactone or eplerenone. Now, if you have LV dysfunction, so if your EF is less than 60%, but have no signs of delayed enhancement, which is good, then we'll start a beta blocker and an ACE inhibitor. While if you have delayed enhancement plus LV dysfunction, we put you in this triple therapy, beta blockers, ACE inhibitors, and MRAs. And we do this sequentially. We do one drug at a time, and we start out slow, and we up titrate slowly. That's the name of the game when we treat patients, to avoid side effect profiles. So arrhythmias, which is the primary thing that most patients with myotonic dystrophy worry about. By the way, in my population at Southwestern, about 40% had some type of LV dysfunction, which is a lot higher than what's been reported in the literature using echocardiogram. And so hopefully in the near future, some of our data will be published to support my claim there. So there are different types of arrhythmias. The most common is AV block, where the circuits of your heart get scarred down or fibrosed. So first degree AV block, where your PR interval, and I have a picture of what that means, is greater than 200 milliseconds. Or if it progresses to second degree or third degree AV block, that's a medical emergency. People faint, pass out. You need a pacemaker very shortly. Atrial arrhythmias is common in the dystrophies, and these comments are both from myotonic 1 and 2. There's no way for me to kind of separate the two. Ventricular arrhythmias is rare. It's about 5% of cases in myotonic dystrophy. This is where rhythms come from the bottom part of your heart, and they can cause the heart to stop and cause what we call sudden death. How do we monitor the conduction system? Obviously, getting an EKG is one method where we try and get it every 6 months to a year. I get it every 6 months. If based on the symptoms we're concerned, we'll get a 24 to 72-hour Holter. If we still can't capture rhythms and someone is symptomatic, we'll get a 30-day event monitor. And if we still are not able to capture it because rhythm can be intermittent and sporadic, then we'll have our EP colleagues. So we're the plumbers, and we have our electricians put in this little device, and I'll have a picture here shortly that shows these Myotonic link devices we implant, and it records your rhythm 24/7, and it can be implanted for many years without any detrimental side effects. So this is a picture of the EKG, and I don't want to go into a lot of details here. And unfortunately, I don't have a pointer here, but the P in the upper graph of the EKG, the PR intervals from the time the P starts to the R, those squiggly lines, that corresponds on the picture on your right. Where it's from what's called the SA node, that's your command center. It sends a signal to the AV node, the middle of the heart. And as that gets more scarred down, then the signal gets slowed down. And if it's above 200 milliseconds, it puts you at risk for complete heart block and maybe one indication for a pacemaker. The QRS interval tells how slow the signal is going through your ventricles. So this is a picture of this Myotonic link device. It's about the size of a battery. It's usually a day procedure. It's placed or implanted in the left upper part of your chest. It's just a little nick underneath the skin, and it's placed subcutaneously, and it can stay there for years, and it records your rhythm. And more of us are using this device in our muscular dystrophy patients, in particular myotonic dystrophy, to identify rhythm issues and better able to detect when something's going on. We can capture it very quickly. In fact, my colleagues at Hopkins are working, they have a clinical study. I'm not sure if it's closed or not, randomizing patients to this Myotonic link versus just clinically following patients to seeing which method is able to allow us to better detect rhythm issues. And that's, I believe it's both myotonic 1 and 2 in that study. And this is, once it's implanted, it records 24/7, it gets downloaded, and it gets fed into a computer that is monitored by our team, our nurse practitioners, and nurses, and cardiologists. These pacemakers, so many patients with myotonic dystrophy, type 1 and type 2, may require a pacemaker. And a pacemaker is implanted in patients who pass out. If they develop third-degree block, we have to implant this device, the electricians, the EP docs. It's a little box, as you can see here in the right upper corner, that's in your placed in the upper left side of your chest. And these wires are transverse and are implanted into the heart, and it will pace your heart if you go into heart block. And that has really changed and revolutionized how long patients with myotonic dystrophy live. And the key is identify which patients need this device. You don't want to implant this in every person because it's a foreign object that we're placing into patients. And not every myotonic dystrophy patient needs a pacemaker. There are other types of rhythm problems, atrial arrhythmias, rhythms from the top two chambers of the heart, things like atrial flutter, atrial tachycardia, atrial fibrillation, which are very common rhythms in individuals older than 65. About 10% of individuals older than 65 have these rhythms, but they're more prevalent in patients with myotonic dystrophy. And how we initially try and treat those are with medications like beta blockers. And if those don't work, then we go to more potent antiarrhythmics. And there are obviously more side effects with these: amiodarone, sotalol, mixilotine. Now, if medications don't resolve these atrial arrhythmias, then my EP colleagues will take you to the CATS lab and they will essentially short circuit that rhythm, right? So they take this wand, literally, and they find where that abnormal circuit is and they burn it. So it's obviously a more invasive procedure. They have to put catheters through your groin and arm, and they identify where the circuit is, and they will burn it. But it's a very effective way to resolve this issue if medications do not stop the reoccurrence of these rhythms. Ventricular arrhythmias, as I mentioned, are rhythms that occur in the bottom part of the heart. They're much rarer. We try medications. If medications don't work, then we will try and ablate, but more often we'll have to put a defibrillator or what we call bi-VICD. 5% of our population with myotonic dystrophy have this, both type 1 and type 2. Not able to really give you further details than that. I'm almost done here. So the prevalence of what we call sudden death, which could be from heart block or arrhythmias, was looked at in this meta-analysis published almost 11 years ago, where they looked at about 1,300 patients retrospectively and about 50-50 in terms of male, females in this population. And the risk of having sudden death in this population, about 70 patients had sudden death. Another 108 required pacemakers. Another 24 patients had to have a defibrillator placed because of what they saw by the EP doctors. So take-home messages. So myotonic dystrophy, I would say all myotonic dystrophy patients, whether you're type 1 or type 2, require a full cardiac evaluation. And it's not only, even if the first evaluation is normal, you need to follow them, see a cardiologist on a regular basis, at least yearly, because this is a lifelong risk, and the risk increases as you age. We have to look for rhythm issues, as well as development of a cardiomyopathy or LV dysfunction or lower EF, that's the other term. We have to monitor your rhythm carefully using Holter monitors or Medtronic link devices. And those that meet certain criteria, pacemakers or ICDs or bi-ICDs can be life-saving. As I mentioned, atrial arrhythmias, the lifetime, sorry, I misspelled lifetime there, risk of developing atrial arrhythmia is about 25 to 50% over one's lifetime. Ventricular arrhythmias, much lower, about 5% of the time. MRI is really the preferred imaging tool to accurately assess cardiac function, and one should at least have one every couple years to fully assess one's cardiac function. And there are medications that can be started if the LV is depressed, and we can actually reverse remodel, improve cardiac function with aggressive medical therapy with at least 3 or 4 of these drugs, as I mentioned below. So those of you who've not been to Kansas City is a beautiful city. I love Dallas, but these are some of my new colleagues in Kansas City. And of course, my colleagues in Dallas. I still co-run the Wellstone Center, which is an NIH-funded program to develop therapies for muscular dystrophy. Dr. Olson and I co-manage this clinic or this center. And these centers are developed primarily by the pressures and advocacies groups like yourself, the MDF, the MDA, the PPMD. These organizations have been vital to putting pressure on Congress to fund more research. And I applaud you for putting on that pressure, because it allows us to work with industry to develop newer therapies. So with that, I'll end, and this is my lab. Happy to answer any questions you may have. I'm a little longer than I said, 45 minutes, but.
Thanks so much. We actually have a question from one of our virtual members that I'm going to start with, if that's okay.
Yes, yes.
So they say, assuming an echo is normal, do atrial or ventral arrhythmias in themselves predict any negative outcomes without any known conduction defects on an EKG, i.e., is a normal PR interval and no conduction defect reassuring in the presence of frequent VPBs and PACs?
So the bottom line is we don't really know. But I would say that having a normal echo and normal EKG, although it may be reassuring for that time period, having reoccurring PVCs or premature atrial arrhythmias still is concerning, and you need to be monitored carefully. And I would actually propose that that individual also get a cardiac MRI, because there may be signs that that individual has delayed enhancement or fibrosis. And if that's the case, treating that individual with therapies, ACE inhibitors, spironolactone is really called for. And so I would not rest on just saying I have a normal echo, normal EKG, because these are genetic disorders and it progresses over time.
Thanks. Kind of following up to that, and then I'll pass it off the mic so we can get some in-person questions. Does vasovagal syncope or near syncope in association with the above mentioned warrant any more frequent monitoring?
Once again, if I was following this individual, it would be a concern of mine. We may not act upon just those symptoms, but we would monitor that individual more closely. And I would actually propose in that individual placing a Medtronic link device to see, can we identify any rhythm issues? Remember, these rhythm issues are very periodic. They're intermediate, and just a Holter, an EKG may miss it. And so having a device that's implanted that can record it is really critical. And that calls into question, this collaboration between a heart failure cardiologist and a good EP doctor to be your team, your cardiovascular team, to manage myotonic dystrophy patients. Yeah.
Thank you. In terms of a statin or another drug that lowers cholesterol, is there anything that you recommend that doesn't tighten the muscles?
Yeah. So great question. And this is a response to all muscular dystrophy patients. Because there's constant muscle injury, many patients with muscular dystrophy are not going to tolerate statins, either to side effects or increase in some of the blood work, the CK and liver enzymes. And so what I've done in my practice, because myotonic dystrophy patients are still, as they age, hypercholesteremia, elevated cholesterol needs to be managed because one can develop blockages of your heart arteries, which is independent of the genetic defect you have. And so Repatha or these PKS9 inhibitors are very potent cholesterol-lowering agents that have been developed, actually was discovered at UT Southwestern. And there's Repatha, there's other now drugs on the market. The problem with these drugs is they are injectables, either twice a month or once a month. So they're injectables. There isn't an oral agent. But these agents bypass kind of muscle injury or muscle tightness or anything. And we've had very good luck in the 12, 15 years I was at Southwestern. We had very good success in placing patients on those drugs. The problem is insurance companies will often say, well, they didn't fail a statin. We won't pay for it until you try a statin. And so then you have to fight with the insurance company to say, listen, you can't start a statin in a muscular dystrophy patient. That's going to be contraindicated, and you have to be forceful. I've never had an insurance company deny me, but I've had to fight for that. So.
How effective are the injections in terms of lowering lipid level and the plaque buildup? Because I just recently had a cardiac carotid MRI, or no, ultrasound, I'm sorry. And I have some narrowing. So, and I'm not a candidate for statins.
They're very potent. they're very potent. They're in fact more powerful than statins. So they will lower your cholesterol, both the total cholesterol as well as your bad cholesterol, the LDL. Is a very, very powerful class of drugs with very little side effects.
Okay, well, that's good.
Yeah.
Another question related to this. For the longest time, I've been told that my having an elevated good cholesterol kind of outweighs the bad cholesterol. But just very recently, my cardiologist or my lipid specialist said that that's not true anymore. What are your thoughts?
My thoughts. So I think they're both right in the sense that, especially in women will have higher HDLs, the good cholesterol, right? Oftentimes they'll be 60, 70, 90, the good cholesterol, HDL. And that's due to the estrogen cycle and everything. But as women go into the postmenopausal phase, that good cholesterol, the HDL starts to lower. I guess I disagree a little bit in terms of what your lipid specialist states, that there is good data that the higher your HDL, the good cholesterol, the more protection there is. But once again, as women age, that is offset by age and the rise in the LDL and the lower of the HDL. So I think both are true, but in general, high HDLs is a protective effect, especially in younger women. So, sure. Okay.
If you don't qualify for an MRI, just to be clear, what would be your secondary measure? If not an echo, would you get a cardiac CT?
Yeah. So first I would fight with the insurance company. They almost never did. I've never been denied an MRI, but I have to kind of fight with them.
I don't qualify for one because I already have an implantation.
So one, you can get MRIs with an implant. There may be some artifact, but I can tell you at Southwestern, we imaged a lot of patients with MRI compatible and MRI non-compatible devices. Now, depending on where you are, the institution may not do it. But both at UT as well as in Kansas, we do it. There is artifact. There is some artifact. But so say your institution doesn't do it, the next best objective measure is a cardiac CT. Because it's all about quantitative numbers and getting more accurate assessments. So cardiac CT would be the next best thing. The only disadvantage with cardiac CT versus MRI is you cannot tell if there's any scarring. You don't have that ability. So you won't have that prognostic indication.
This is a follow-up to her question about HDL.
Yes.
I recently read a study that ultra-high HDL, mine is like 101 to 105, and it's gone up as I've gotten older. I read a study that was not good for your heart.
So now that I don't know, I can't answer that question because that's a little beyond my kind of repertoire. I unfortunately cannot, I don't have an opinion on that.
Okay.
So I would refer you to your lipid specialist or a cardiologist that has expertise.
Yeah.
Okay.
Okay, we have another question from Tom, one of our virtual attendees. He says that he, without knowing he had DM2, wrestled with atrial flutter for 8 years and he didn't have luck controlling it. Had some ablations, a variety of meds, and it appears he has a cure arrhythmia. He's been on a pacer for 11 years and has now gotten a throat ablation, and things are looking good. He takes a drug called Eliquis and does yoga, which used to raise his ventricle rate and atrial rate and now doesn't. He's wondering if an AV node ablation is a typical treatment and should it be.
So I didn't mention that. So those that have refractory atrial arrhythmias and patients are symptomatic, you can ablate the AV node, so the connection between the atrium and ventricle, and then you're pacemaker dependent. So the downside, so it is a therapy, but it's more of a later, more advanced care. But you are pacemaker dependent. In the use of Eliquis, actually, I didn't go into that, but almost anyone with reoccurring atrial arrhythmias should be on Eliquis or an anticoagulant, because it does put you at risk for clots and strokes. Eliquis or Coumadin, these are all the same, but yes, so it is a therapy that I would advocate in someone who's failing our conventional therapies. So, but, yeah.
Hi, Dr. Mammen. Okay, when I was seeing you, you had put me on the 3 drugs for blood pressure.
Mhm.
And then I had a spell there where I had a big drop. And now I've had another spell, and I'm only taking metoprolol, half pill, but my blood pressure still went down to 75. Now, I did have COVID.
So hypotension is a problem in many muscular dystrophy patients, and oftentimes we withdraw some of these meds because they do lower blood pressure. Maybe I'm reading into your question, but if the question is, is COVID having something to do with your hypotension? I don't know if that's part of what you're asking me or not, but
Or the lowering of the blood pressure.
I don't really know that answer if COVID has caused that. My guess it's the progression in kind of the dystrophy and your blood pressure. I don't think that COVID is the culprit here, but I can't answer that, to be honest. So, but I can talk to you more about that in private. So.
Hi there. So I've been told I have a right bundle branch block, and I also have intermittent lightheadedness, and I've worn the Holter monitor, and they say they never find anything. Don't worry about either one of those things. Do you have an opinion on that?
Yeah, so the French group have actually looked at this. Individuals that have left bundle branch block or conduction delay going to the ventricles. So if you're right or left bundle branch, it tells us that there is scarring that's forming in the conduction in the ventricles. And the French group has proposed that if one develops left bundle branch block, and I know you have right, but in left bundle branch block, they actually propose as a class 1 indication to study your circuits, to do an EP study. To assess the intervals and how quickly signals go, and if they're slowed down, that may be an indication for either pacemaker and or defibrillator. With right bundle branch block, it's not as clear, but I have had cases where when there's a sudden change in the EKG and before they had normal rhythm and now it's a right bundle branch block, I tend to be very aggressive, and I'll send them to my colleagues, the EP docs, for consideration of at least an EP study. Another option they can do is implant Medtronic Link. These Medtronic Link devices are very, very relatively benign of all the things we do in medicine. It's subcutaneous. It can stay there for a long time, and it can record your rhythm. But I would do one of those things. I personally would not just stop there. But I'm also perhaps one on the spectrum of being one of the more aggressive cardiologists in the country. So there's some.
Hi, I have a question about my husband. He's actually in the hospital right now at Stormont Vale in Topeka.
Oh, yes, yes.
And we doctor with Dr. Statlin at KU Med.
Uh-huh.
And on my chart, it was showing that his EKG was abnormal. And I won't read you everything. But
Okay.
one thing it does say is about the non-specific intraventricular conduction delay.
Yeah.
So does that just mean we need to do some more stuff and maybe?
Well, it suggests that something, sure, I'm happy to see you. Yeah, so it does, so a non-specific intraventricular conduction delay is essentially, the circuits are starting to scar down. It doesn't meet criteria for right bundle branch block or left bundle branch block, but it tells you that something is evolving. And, you know, if I was seeing your husband, I would get an MRI and maybe put in a Holter and or do an implantable a Medtronic link to better understand. But I would not personally. I would not ignore that. But is it you know imminent or dangerous right this minute? No, but it does highlight that something needs to be done. So I think there's someone. So and Jeff and I are just beginning to form an alliance, and he's starting to send a lot of my patients that I used to see in Dallas to my clinic. So, but.
With the Medtronic link,
Yeah.
Can you still have MRIs, or is that?
Yes, you can. You can. Once again, it depends. You know, I've been always at institutions that were more academic, and we do it. At some institutions, they may be very strict and not do it, but at most academic centers, they don't have a problem with that. They have to maybe change some of their protocols, but usually that's not an issue. So.
And then going through security at the airport, that type of thing, is that an issue?
That's a good question. So I can't. What I would say from a safety standpoint, I would get patted down because it's a device, it's an electronic device, right? And you're going through a magnet. It could cause some malfunction of the device, and so I would get patted down.
Okay.
So
Thank you.
Sure.
Is there a specific type of cardiologist we should be seeking out, the specialist doing a specialist, or the general cardiologist?
So of the 6, so I know that there are about 10 clinics around the country that devote their care towards neuromuscular patients. They're all heart failure cardiologists. And I think we are kind of the most well-equipped to handle this. A good general cardiologist could, but the reality is there are very few general cardiologists that have the experience or knowledge to really understand how the neuromuscular disease affects the heart. So.
Question: is there a list of those cardiologists?
Say that again.
A list of those cardiologists.
I didn't understand. A list. They're all in my head, I can tell you. I mean, they are all over the country. You know, there's a guy at Hopkins, South Carolina, Rochester, Chicago, now Kansas, LA, and Seattle. And I can give you specific names if that would help, because we're a small group of cardiologists.
North Carolina or Virginia? So
there is one guy at Duke, Paul Rosenberg, who's a heart failure cardiologist, who's developed an interest in neuromuscular disease. Paul and I trained at Southwestern, great guy, been at Duke for about 20 years, but he's one at Duke. So, and there's someone at South Carolina, Daniel Judd, at Charlotte Charleston Medical College of Carolina, Medical College of South Carolina, I guess.
Can I just make a quick comment
Yeah.
about, the Myotonic Dystrophy Foundation has a Find a Doctor map. So on our website, and you can go in and filter for cardiologists and look, it's an interactive map. You can select where you live, and people will let us know if they have a doctor who specifically knows about DIA or has worked really well with them, and we continue to update that map. So that's a really great place to go.
Thank you.
We have time for one more question.
So I was gonna ask more specifically, in that list of 10 cardiologists / heart failure cardiologists, is there anyone in particular that works very well with an electrophysiologist?
I mean, there are several, including myself. There's a group at Hopkins that works very closely together. So there are, I would say actually all 10 of them have close alliances with EP physicians, because EP physicians are critical for the care. Yes. And all 10 of the ones that I know, there may be more, but the 10 that I know that are most prominent that publish and studied have alliances with electrophysiologists.
Thank you.
Sure.
Good for you. So we talk, and I can answer any questions.
All right. Thank you.